Welcome back to the Sports Medicine Project, episode 107 with Professor Ian Harris. A very thought-provoking episode. If you don't know who Ian is, he is an orthopedic surgeon who practices in Sydney. He is the Professor of Orthopedic Surgery at UNSW. He is published widely on surgical effectiveness, and that is what we are talking about today in surgery and allied health. He's published 2 books, one which I'm halfway through at the moment, which is Surgery, the Ultimate Placebo. It's pretty good. His other book is How Doctors Are Betraying Their Oath. Now, what we cover in this episode is a whole range of topics, but broadly speaking, rethinking medicine, PRP and other treatments, diagnosis and treatment decisions, the clinician's role and informed consent, the impact of the COVID-19 pandemic on elective surgeries, the persistence of ineffective surgeries, you're going to love that part, understanding what placebo is, understanding the ethics and how people actually improve and why they might improve, and the key findings in surgical effectiveness. This episode will definitely make you think, and I know what you're going to enjoy it very much. So as always, look down to the chapters in your podcast player. You can skip straight to Professor Ian Harris, or you can listen to Kelly and I run through our clinical week. We have some interesting cases from tibial bone stress to sesamoid to runners to back pain to talking about some new research coming out looking at heavy resistance training in the older population. I hope you all enjoy it, and we'll speak to you all next week. G'day, welcome back to the Sports Medicine Project, episode 107. Now, I am here with my favourite co-host, Kelly Kortic. Welcome to the project.
I feel like the energy levels aren't matched when we're recording at 7:45 in the evening.
Yeah, I am very pumped up, and I'm going to tell you all why. It's been a couple of years. Kelly and I have been using USB microphones, and we finally got dual sets up. So Kelly is over one side of the room. She's basically over the other side of the world, and I'm standing up at the desk, like dancing right now because we can do it. Because how we used to do it is we would each face into the mic, and we would have our fierce clinical discussions. We would be staring into each other's eyes, ready to go to the death. But it's good to be here with you.
I'm looking forward to it.
Yeah, let's
Little do the listeners know, though, that we did attempt to record this last night, but you actually got the microphones wrong.
Yeah.
So
how upset was I? I was fuming, and you said, "You're gonna get it, you'll do it," and then I got it, and I was real happy.
We didn't last time.
No, well, I can see it right now. I can see it flowing. But anyway, let's get stuck into it because I've only got 30 minutes of your time, which is very valuable. So if you're new here to the Sports Medicine Project, it is your standard episode. We have a lovely guest, Professor Ian Harris, coming on talking about surgery, sham surgery, and if it is ethical to look at sham surgery in the research. Now, you'll be able to skip through to the chapters, which will be around 30 to 35 minutes. So if you open up your Spotify podcast, it'll have chapter 2, click that, it'll take you straight to the episode with him, which I know you're all going to enjoy. But Kelly and I are going to be, as we always do, talking through our clinical weeks, talking about the cases that we saw, and we had a pretty interesting week, didn't we?
Well, this is what you said last night, and I don't recall it last week being all that interesting.
I swear I remember you coming home and saying, because I was like, I had a really interesting week.
I had
I wanted to get your
interesting
opinion.
patients, but I wouldn't say it was anything too out of the ordinary.
Too much, yeah. Another interesting case today. Like, it seems to be people not in allied health, like, it's massage therapists and acupuncturists just seem to be saying the wildest things to patients. This is unrelated to my week, but I saw someone today that's got a really pretty low grade first MBJ synovitis, training for an event coming up in 3 weeks. Has a perfect pair of carbon plated stiff shoes, and I said last time we caught up, I said, great, I want you to wear these shoes on the majority of your runs, about 80% of them, just to help unload the toe. You feel a lot better. When we did your running assessment, you felt a lot better. The toe's great. It responds well. Let's just do it for the short term. Saw the massage therapist, and the massage therapist was like, are you sure you want to run in those? And then this is what the person was telling me. They was like, yeah, the podiatrist said it's okay. It unloads the big toe. It's not forever. We're just trying to help settle it down so I can keep training. And they said, oh, listen, I've seen so many injuries come in just because of those shoes. I don't know if you should be in them. And just the patient kind of laughed, and I laughed a little bit. I was like, we're not going to be in them forever, but just wildest things that they're getting told. And obviously the divide between that is who are they going to listen to and who are they going to trust. But you wonder what else they sometimes get told about some of the things that we do. Yeah, I know you've had a couple of...
I had an interesting one today with a patient who had seen a previous physio. And they were from a different interstate, so I feel like I can talk a little bit more freely about the physio that they had seen. They came in with patellofemoral pain. They were a runner and had been increasing their training load, like gone from 0 to 10 Ks in the space of 3 weeks.
Wow.
And developed patellofemoral pain, which, would make sense in that sort of rapid progression on no baseline, like not hadn't done anything previously. And the previous physio that they saw just did dry needling. That's all they did. And they had experienced a little bit of relief from it, which is good. I was like, was there any discussion around load management? Did they give you any exercises? Did they give you any stretches? Did they talk about anything else that might be contributing to this? Did they actually explain to you what this is? And they hadn't done, she said that all they did was said,
dry needling.
Yeah, you've got patellofemoral pain. We're going to dry needle this. Make sure you follow up with a physio when you're interstate and to have more therapy. And so that's why they were in for more dry needling, and I just bombarded them with all the education.
It's crazy. I mean, if you think about
it was crazy.
What it is to the joint. I mean, as you said, you can get some relief certainly by dry needling, but if it's the patellofemoral joint, whether it be some fluid, inflammation, whatever's happening internally within the joint, dry needling around it isn't going to help the joint. It might help with some relief and it might help change something, but if you just boil it down to the basics, it's not going to do too much for the joint.
Not at all.
Yeah, you see those cases where people still improve. I've had people, and I don't know why it's so common in the forefoot, but I've seen people that have their dorsal forefoot dry needle, like intermetatarsally. I'm like, what are you needling in there? Like the lumbricals or the bursa? A little bit odd. I mean, people can get relief, but it's going to be in combination with, like you said, with other things. I mean, you can do that stuff if you're...
But not in isolation, yeah.
Yeah, doing some run programming and load management, but...
No, I hadn't even touched on the fact that the training load had increased by such a drastic amount.
Yeah. Now, to be clear, we are both accredited dry needling therapists, aren't we?
We are. I was actually telling this patient that today. I was like, I actually know my way around a needle. I choose not to do it. I can do it, but I would opt to do other things.
Yeah, damn. I tell you what, the bloody people that took my $600 when I did that 2-day course, I'm never going to get that back. I think now, so say like going to Rich Willie's course or Christian Barton's or Greg Lehman's course for the same amount of money, if in my mind, I'm like that or dry needling, that's crazy to think that I would think I better go to needling because that's what people need. But you think that when you're a new grad, you're like, I need to do my dry needling course. I remember people in my cohort were doing, when I went through podiatry, they were doing needling in the 3 months before the graduation thing come through.
I thought the dry needling course was useful as an anatomy refresher.
That's true.
But you could do that in other ways as well.
Yeah, but you got it hard because you're a physio. I only really need to know the anatomy below the...
Did you dry needle the lumbricals?
Well, we didn't do forefoot. I think that might be for...
That's the advanced course.
Yeah. Yeah, I mean,
not to trash talk dry needling.
No, because
there's nothing wrong with using it.
No,
I just choose not to anymore.
Yeah, I don't,
based off what I've learnt about it.
Yeah, I agree. I think if I look at my clinical hour or 30 minutes I spend with someone, I think that I should be doing or focusing on these things. But in saying that, who am I to say that this is what I value? I've got my biases and what I believe in, but I don't have time to do that. But in saying that, I'll do Shockwave. And as we're going to find out in this lovely podcast, that Shockwave may be no better than sham or exercise or really anything. But interesting. Let's get stuck into the week. You want to hit your week first? Yeah, I'll go first.
You go first because we might just skip mine if you carry on like you did last time.
Yeah, all right. So, clinical week, run me through your thought process. Tell me what you would do in this case. So, somebody comes in the clinic. They walk in, they have a unilateral unilaterally changed their position of their foot, so they're loading weight more laterally to try and shift weight away from their big toe, and they have developed almost their toe sitting in almost a varus position to try and take all the weight from the plantar first MPJ area. 6 months ago, had an injury, an acute injury, fell and bumped the bottom of the foot. Had an X-ray that was all clear, said it had a bipartite sesamoid and clear of any fracture, but has had ongoing pain for 6 months, has deselected from all activity, no running, really no walking, feels a lot better in shoes. What are you thinking? What clinical tests are you going on for?
I'm struggling to hit this with the authentic response because we talked about it last night. But image it. I think you probably need to image it. Like if it's 6 months down the track and it is still presenting as if there is some sort of pathology within the toe, if there's like swelling and to the point where they're significantly offloading it to try and get away from it, because that area does have the risk of developing something like an avascular necrosis in that sesamoid.
Yep.
If it's been a fracture rather than a bipartite sesamoid, I think that that's something that needs to be investigated and at least ruled out. It's possible that that person has developed a compensatory gait pattern because it was sore for a long time and it's just really sensitive. However, I think there needs to be an investigation to ensure that that's not the case.
Yeah, and I did forget to mention that it does know you're across the case. I did forget to mention that it has been swelling a lot too, like 6 months of swelling post there. And sore over the sesamoid. I agree. When it comes to imaging, though, it's difficult because X-ray isn't going to give you the best indication if it is bipartite. You can look to see the gaps between the sesamoid and see if it's more jagged. Again, you can't tell if there's any edema. You might be able to tell if there's been some structural change over 6 months. But then the question of is it MRI or CT? And MRI should give a good indication. And if that's not exactly clear, the clinical symptoms, talk with a specialist and potentially a CT. But
would you send for that yourself or would you just send straight to a sports doc or ortho?
That's a good question. Well, I'm quite unique working with the sports doctor, so I've got the ability to just walk out and say, hey, what do you think of this case? This is what I'm thinking. Would love your opinion. Without them actually giving an opinion, I just say, hey, this is what I'm thinking. So we're going to get an MRI in that case. And because we're unclear somewhat of the risk and potential diagnosis, I definitely think the sesamoid's involved. We also went into a cam walker as well. I mean, it's been 6 months and they haven't been in one, but the potential for it to be something quite severe is a lot higher than your typical sesamoiditis. And if they're in a cam walker for a week and it is just sesamoiditis, well, we can take it out and there's really no harm. There's not much collateral damage to the other tissues.
Interesting.
But, would you have put someone in a boot?
Well, I don't know what a boot would do other than, I think if they've already, I know, but if they've already been offloading it if they've already been on it, walking on it for 6 months, what's a boot going to do at this point in time? Yeah. Like, I don't think a boot's really going to help it to heal. I don't know. I guess it would. Maybe. Like, probably symptom dependent, I would say. If it's
were pretty, it was pretty uncomfortable.
Yeah, so then in that case, I'd pop them in a boot just to make it feel better while they're walking. But I wouldn't really know for how long because, I don't know, like, is that actually going to help it to heal if it hasn't healed already?
Yeah, well, it's a good question. I mean, this is going to be a case, and I'm thinking it is going to be very likely to be a referral to the specialist, but I think even as imagining the worst possible scenario, in that case, it's always going to be safer to put someone in a boot because it's a lot easier to take someone out rather than something potentially happening. It's like, well, why weren't they in a boot? So
yeah, that's true. I think it's like better to initially just go conservatively. But
yeah, and in these cases, as we've spoken about on the podcast a lot, I'm very open and transparent with people. Like, this is what I believe could be happening, and this is why I think we need to go into a boot. And I find a lot of the time when we're pretty aggressive with offloading, people are like, yeah, okay, I'm happy to do that because, as you said, these are the consequences. I had someone today suspicious of a Jones stress injury that had a big increase in their walking, a little bit of night pain, recovered. There's enough evidence there to send for a scan. And the problem is because MRIs are just out of pocket. I mean, I wish there was some way for them not to be so expensive. But we just spoke about, like, this is the cost of them, but this is why we need to send for the scan. And very rarely do we use MRIs unless we, truly believe it's going to change the diagnosis. And in these cases, with a high-risk stress injury to the bone, of course, we need to be clear with that.
Yeah.
All right, Tuesday. Geez, we're already pretty long in. We'll see how we go. Right, so Tuesday, a suspected bone stress injury, but so distal tibia, sore to palpate, dramatic increase in running and intensity with a race coming up. But oddly enough, no discomfort to hop. Now, we were speaking about this kind of off air. I haven't seen a stress injury that isn't sore to hop on. So what do you think of that? Like if you were to see some clinical symptoms, aching throughout the day, bit of discomfort at night, but they can hop and it feels okay, like what does that change? Does that change anything with your management or thinking diagnostic wise?
I think I've got Dave Renfrew in my head with this scenario, in that he always reinforces the importance of not making rules around particular injuries. Yeah. So as soon as you make a rule, because like the HOP test is a very sensitive test, obviously, for bone stress injuries, but then there's going to be potentially an outlier who doesn't have a positive HOP test but still has a bone stress injury. And if you've created a rule in your head that says this person has to have pain on hopping, otherwise you've like ruled out a bone stress injury, then I think it's going to become that's a problem. So you want to use that test in conjunction with all the other findings to make a decision around, as we just said, is it going to change your management? Is it going to change their ability to participate in their sport or any upcoming events, et cetera, et cetera? And if the benefits of scanning it outweigh the
potential consequences.
I was
missing it.
Yeah, exactly. Yeah. Then I think you kind of have to, regardless of whether they have pain on hopping or not. And I think that goes for a lot of injuries. Like in uni, they teach us they probably have to teach us in some ways a very black and white way of thinking, because it helps us to try and help with like pattern recognition and coming to a diagnosis at some point. But then in real life, in clinical land, there's a lot of cases or scenarios where a person's not fitting into a particular box, and you need to have that flexibility around your decision making around what else could be going on.
It does help your ruling in and ruling out. And like the test you're referring to for the tibia, if someone's got less than 5 centimeters of tenderness and they have pain on hopping, what's it like 95% sensitive, not specific but sensitive. So ruling in and ruling out is different too. If you had those clinical tests, it's very hard to rule it out and you're very likely to pick it up. But as you said, it doesn't mean that it can't be. And I've been proven wrong time and time again, where I'm very sure that this is something like a bone stress typically, and it hasn't been. And other times where there's a little bit of evidence and it has been. Yeah. But I was saying, as a clinical test, like, and this is what I was doing in getting them to hop, and then I was pushing into where it was sore and just seeing, do they have some discomfort? And they could pretty easily say, yep, it's really sore there. So that's something that I've done differently. Wednesday, just interesting, someone getting such a good response to a TMT joint corticosteroid injection. They had osteoarthritic joint, had some pain. We've been managing for a while now with inner soles and shoes and some activity and load changes, plus doing some general lower limb strengthening stuff. But had a flare up of the joint, had an injection, and it basically took all the discomfort away. And then it's come back just a tiny bit. This is 12 months later, but just an incredible response to a corticosteroid injection, which the research would suggest, per David Hunter's interview that we did, I think it was episode 88, talking about the average is about 4 weeks in the osteoarthritis research for corticosteroid. But just interesting to see someone have such a good response to that. Like, do you ever see that in the back? Do people...
No,
or the hip, or not really?
We were talking about this off air. So I had a patient yesterday who had what seemed to be quite clear-cut discogenic lower back pain, and had a cortisone injection and really had no response whatsoever. So it just didn't change his symptoms in really any way. I have seen it in the back though, like where there is a positive response. So particularly if there is a like an obvious, I guess, inflammatory component, that's when they will do well with a cortisone injection. But maybe in this patient, there was maybe more of like a mechanical component or something else that was driving like some sensitization or some muscular guarding perhaps that might have been driving his symptoms a little bit more, because the cortisone injection didn't change a single thing, even though there was some signs that it was inflammatory driven, and his symptoms correlated with his imaging findings. Interestingly though, he actually had a really good response to oral anti-inflammatories, just not the cortisone injection.
Yeah, that's odd, isn't it? Because you would think, well, I've had some people that have been taking like oral anti-inflammatories for just a joint synovitis, and they have an injection in there, and it completely takes away all their discomfort. It's incredible, but it's funny how that didn't work like that. Obviously, that area wasn't the driver of nociception.
Yeah, well, like I guess it just comes down to, like, particularly in the back, how many things might be influencing someone's pain or symptoms. And for some reason in the back, it just seems like there is obviously more things that could be contributing to it.
Yeah. The back, the back to me just seems, maybe because of all the research and things, it just seems really complex, but it doesn't specialize to each tissue. Maybe just the foot in my mind, maybe just because I see lots of feet, in my mind, feet just make so much sense. I'm like, yeah, this bone goes here, it's this nice structure, I can feel, I can palpate. In the back, you can't really palpate really everything. It's all kind of laid on. Yeah, we do have it easy. And then you're thinking like the tibia, that thing's easy as. You can palpate anything on that bad boy. Anyway, Thursday, interesting case, a runner with forefoot pain, and we did the typical shoes, simple deflection, and we did some run assessment. But funnily enough, they had previously seen a acupuncturist who said don't do any activity. They were doing some running, some stuff at home, and they were doing some indoor sport as well in flat shoes. So a couple of contributing factors is flaring up. Said take 3 weeks off completely. So the other therapist said 3 weeks off completely. We'll do some acupuncture, come back and see me, and we'll see how it goes. And he said that he went back and they said, why isn't this better? I can't believe this isn't better after what we've just done, which is just take 3 weeks off. And we were chatting, like, to have the confidence to say that to someone, I would feel like the biggest imposter to say, as if your body hasn't healed. Why aren't you better? Like, what's wrong with you? That just, I couldn't believe that. And if you say
that to the wrong patient, then they just get that feeling of, oh, it must be me that's the problem. Like, it can't be the intervention. I'm the problem. Like,
which
I just
was rest.
feel like that's so unfair.
Yeah. And
well, rest and acupuncture, I guess.
Yeah, and this person was a really nice person, just wanted to do some activity, and we changed a couple of things. We basically started a whole return to running program, did some foot strike changing and some cadence and deflections and optimized the shoes, and it responded quite well. But anytime you rest completely, your overall capacity is going to drop, and if you go back to try and load again, it's just going to flare up. But I just couldn't. I imagine it just gives me some kind of odd feeling. Imagine saying that to someone.
Yeah.
Anyway, you want to hit your week? Hit me through.
I'll whistle through my week.
Yes, I thought that you weren't going to do it.
Real quick,
love
though.
hearing your week.
I'm really going to whistle it.
Yeah, whistle through.
Whistle through. So on Monday last week, I read a interesting paper, which was actually a branch off a bigger paper, which is a really cool paper, and I was actually really enjoying reading it. But I was more interested in the findings, which were, disclaimer, right up my bias. So
yes, feed the bias.
I know,
feed the monster.
And so I'm actually now rereading the paper and trying to really pick apart the, like, if it wasn't in line with my bias, how would I interpret the findings?
No, don't you dare do that.
But isn't it funny though? Like, you read a paper that's aligned with your bias and you're like, yeah, this is awesome. Like, I believe everything. And then you read a paper that's not in line with your bias and you're like, oh no, there wasn't enough people. There wasn't an intention to treat analysis. They didn't have a really good rehab program, so that couldn't have been right. And then you just find excuses. Whereas this one, I'm like, nah, well, that was great. Although I have to say, it was a pretty good paper. So it had over 400 people. It's called the LISA trial, or the LISA study. And it's looking at retiree aged people. And they followed them over or they had an intervention group, 2 intervention groups. One of them was heavy resistance training, and then the other intervention group was moderate resistance training, and then they had a control group. So the control group, they just said, live your active life, carry on. The moderate intensity intervention group did 3 times per week at home. Sorry, 2 times per week at home, 1 time per week supervised, doing like push-ups, squats, banded exercises, working towards like 12 to 15 reps type of intensity, so moderate intensity. And then the heavy resistance training group was in the gym, just using machine-based exercises, so like knee extensions, seated chest press, nothing that's like axial loaded, that would be I guess more recommended when we're treating like bone density, I suppose. It was more machine based, but they worked more towards like a repetition max. So I think they started with like a period of just learning the technique, and then they worked up towards like 85% of their 1RM.
You say there were squats and deadlifts?
No, there wasn't.
No, okay.
All just machine based. There was, in the moderate intensity group, they had squats, but just like body weight.
Oh, they give them some calf babies?
Yeah, they did.
Oh, yeah.
They did.
Well, that's bone loading, and then I guess
but this is in the moderate intensity group,
Yeah.
so they didn't have weight. It was just body weight.
Yeah.
And then, so they did this over a 1-year period, so 3 times per week for each group.
Oh, good on them.
Yep. And they followed them 4 years later. They retested them. So the main thing that they were trying to assess was knee extension strength. That was their primary outcome measure. And the control group and the moderate intensity group, so they all, the control group didn't increase after 1 year of doing their exercises. The moderate intensity and the heavy resistance training group increased after 1 year of doing their exercises. But then 4 years later, the heavy resistance training group had actually maintained their strength.
Whoa.
From, I don't know what they did in the meantime, but then the moderate intensity group lost strength, and so did the control.
So
how crazy. So it's basically saying that a 1 year period of doing heavy resistance training has long-term effects.
So what did they say between year 1 and year 4? Obviously it matters what they did in those years. Did they continue training?
They weren't doing the supervised training. I don't know what they did.
Okay, because
I don't know.
Yeah, I mean, like, that's really important, because you would, I mean, from the research, like sarcopenia and stuff like that, you would think that if you don't do any resistance training, regardless of how strong you are, you will lose something. But obviously, if you've got more in reserve, you're going to end up at a place that's still higher than what people would be if they didn't train. But that's incredible. I just need to know what they did in the middle, because you don't know. Like, if they continued training.
This is, well, I'll read the article properly and we can talk about it next week.
That's cool though, but that's just more reason to, I mean, we speak about this all the time. Lift heavy, and to tell people that as clinicians, our job isn't done when, it just feels like a business to doing it, shaking hands. I guess maybe our service or our education can go so much further than, okay, you don't have any pain anymore. Awesome. You don't need to see me, which I agree with if someone can self-manage and they're going okay. But we can give the advice to people like, hey, you can continue to do good calf and good quad and good hamstring, good upper body training, because there's good research to show that this is healthy for your overall capacity. And that's another example. Like, if someone's doing really well, they get back to their activity, great. You should probably continue to maintain some level of resistance training in your life. I want to say forever. I say foreseeable future, but I think forever. Yeah.
Anyways, Tuesday, I had a patient that I think had compartment syndrome. I've never clinically seen that clinically or diagnosed it or suspected it as like a true compartment syndrome. They had been not really increasing their training load, just doing their normal sports, but were complaining of this feeling of pain and burning and fullness in their calves after playing sport, which was a running-based sport. And then that was on Sunday, and then Monday it would settle down. They'd have the whole day to rest, and then Tuesday they'd have training and they'd get through most of training, but it was just incredibly sore and just get worse as the training session went on. Then by Wednesday's training session, they pretty much had to pull the pin within like 5 minutes of training because it was just too intense. And then testing them clinically, reproduce their symptoms within like 5 seconds of walking uphill on the treadmill. And just that feeling of pain and fullness and burning in both calves could also reproduce their pain with hopping and jumping and calf raises as well. So
that's interesting, because you wouldn't expect. I have seen a lot of compartment syndrome because the doctor that Dr. Neil Halpin, who we work with, he sees a lot of them and does a lot of the testing. But just coincidentally, they've come into the clinic, and I've seen quite a lot. I've seen I think 9 in the last 12 months, which is really odd for me to see because they're not very common. But that's interesting in the fact that they were getting, like, they could jump and bring on the symptoms. I don't think I've ever seen one.
I think it was on the back end of making it sore from calf raises.
Did you feel the calves?
Yeah.
And they were rock solid? Yeah. So, and that's usually a giveaway sign. So then, obviously, they need to have the compartment testing where they measure the pressure inside the compartment. But so you got them up on the treadmill, got them running on an incline.
Nah, walking.
Yeah, walking. I haven't seen, and it just randomly come on because typically the ones that I've seen, typically people have a history of either deselecting from activity or they've had it for a really long time. And I just keep getting to this one point that it keeps stopping me. Why is that happening? But this sounds like it just got progressively worse over 5 days.
Nah, it's been a while.
Been a while. Okay, that's interesting.
Yeah.
That's a good case. I've seen, so you can do, I mean, you don't have a ABI machine, but you can get them to do it and actually check their pulses as well, and to see if their leg changes colour.
Nah, it was weird enough for me that I was like, even if it's not compartment syndrome, it's something that I'm not comfortable treating.
For sure.
You need to go see the sports doc. So I think
sure.
that was my clinical suspicion, was it was something vascular related.
Yeah, I was going to say, what's your differential?
Well, maybe something like a popliteal artery entrapment,
yeah.
but it was something that seemed to be like vascular in origin. So for me, it was enough to be like, this is weird and I think you need to see the sports doc.
Yeah, for sure. How's a case that I've heard someone that had compartment syndrome testing, and what they would get is it would get that bad and take up that much pressure that they would get a functional foot drop because it would compress the nerve. That's incredible, isn't it?
That is crazy. The last one that I'm going to give you for my week is Wednesday. And it was something that we were talking about last Wednesday when we were talking about differentiating perineal and tib post tendinopathies.
Oh, yeah.
Because I previously had tried to rule out a perineal or a tib post tendinopathy by taking the person's foot into end range, like inversion or eversion, and getting them to resist against me as hard as they could. And then Blake and I were talking about that, and we were talking about in an athletic person or a more active person who probably has a higher level of capacity, it probably needs to be more velocity dependent. So there needs to be a speed component when we're testing the tib post or the perineal in a more athletic person to either rule it in or rule it out, rather than just like an isometric resisted inversion or eversion. Because in comparison, if it was an Achilles tendinopathy, doing an isometric plantar flexion wouldn't really bring on their symptoms. So why would I expect it to in a perineal or a tib post?
Yeah, so you said we would need to do it because it's an athletic person, but you mean because it's a tendon, and tendons don't like, when they're irritable, they don't like the high tensile load.
Yeah, but I'd say in someone that's non-athletic, I would often see that in resisted inversion or eversion to be enough to bring on their symptoms.
But then is that a tendinopathy then? Because in the Achilles, if someone does a slow body weight single leg, they usually don't have much discomfort at all. So then if you're doing it...
I reckon they do. In an inactive person with a tendinopathy.
Okay. Okay. I guess if it's irritable enough, but if you do a slow isometric, I'll grant you that. If someone's got an irritable Achilles, they do a slow single leg calf raise and it's sore, but that's obviously not high tendon loading. It just needs to be really irritable. So does that mean
But it's high tendon load in relation to their normal or their baseline?
Is that right?
Yeah, I think so. I think it's all relative. You jumping on the spot is not not challenging for you and your tendons.
But it's about the tendon. It's about the physiology of the tendon. It's not about the person.
It is about the person.
Well, it doesn't matter. No, it's about the tendon because
it's about the tendon. But someone who's deconditioned or sedentary and hasn't jumped in the last 10 years, the hardest thing that they might do is a single leg calf raise.
Yeah, but it's still not loading. The tendon loads aren't that high.
But it's high relative to their baseline.
Okay. Because I'm just thinking of, you load the tendon like an elastic band. That's how the tendons are going to be most provoked. That's how most of the load goes through the tendon. Wouldn't it be more of the muscle that you're going to be loading if you're doing an isometric contraction?
Well, have you not seen someone with a tendinopathy who has symptoms when they're doing a calf raise?
Yeah, but that doesn't... I guess if it's irritable enough, but it's
not... but it's not... We're not talking about provoking... We're not talking about loading the tendon. We're talking about provoking symptoms.
Oh, okay. I think they're the same thing because you're trying to provoke the tendon to rule in or rule it out.
You are provoking the tendon in some cases.
Okay, but it wouldn't be as... I guess it wouldn't be as sensitive then if you're just doing it slowly. Like, you can't rely on it that much if you're doing it slowly, that's sore, even if it's in someone that's inactive. Because, if you see someone that's inactive, you say, and their capacity is lower, and you get them to an isotonic tib post contraction, how often are you seeing that sore? For me, it's not much.
If I take someone to end range eversion and get them to contract, invert against me, against resistance, it's often sore.
So how do you know that's a tendon and not a peritendon?
I don't know. It's the same I would, in someone that's inactive, I wouldn't be getting them to do anything that's high provocative load anyway in that initial phase. I'm going to be offloading for the most part in that scenario.
Yeah. So
but I would go off the behavior of it. So if it's a tendon that gets worse with activity and it has come on acutely, it seems, then maybe I'd treat it more as a peritendon. But if it's a tendon that warms up with activity and they have that typical startup stiffness and those sorts of signs, then I'd treat it more like a tendon.
I think I've overdiagnosed tib post tendinopathy when it's probably been some kind of tarsal tunnel peritendon, because I've done that as well, and they can be sore obviously in the tarsal tunnel. I'm talking about tib post here behind the malleoli, and it's there's lots of structures in there, and I'm probably poking into more than just the tib post tendon. But from what I've read, the tib post tendon is under the most amount of compression in the tarsal tunnel, and that's the area where it's most avascular. So if you evert your foot, you're compressing the tendon within the tarsal tunnel, which is exactly like an Achilles, where you're doing the compressive load when you're loading into more dorsiflexion.
Which is what I said, isn't it?
Well,
I'd evert the foot and then get them to resist against it, which is a compressed tib post where they're loading against.
Yeah, but it's still not fast, because you would know with an Achilles, if I do
Which is that's the point of my thing. I said I guess in an athletic person, then you'd want to do it more quickly. And you could do it in a non-athletic person, I guess, too. But I just don't think... I think I've seen the symptoms be provoked when I'm not doing it with velocity.
Yeah. What I'm struggling with is I see a lot of tib post and perineals, and people don't have a lot of pain to invert and evert. Maybe I'm just not getting them to do it at the right range. Because if I get someone to invert against my hand, that feels fine, but they still have just come for me to push into. So then the question is, do we then need to get them to do it quickly, because that would be high tendon loading? Yeah,
but then again, this is just similar to what I would say with that conversation we had about the bone stress injury. I just still don't think it's worthwhile making those rules around it. So you're using their subjective history and taking all of the clinical symptoms together to come up with a suitable diagnosis based off what they've reported to you from their story.
Yeah, I'm not making a rule about it, but what I'm saying is, if you saw someone with Achilles tendinopathy and they could jump and hop with no pain, in my head, I'm not saying, all right, rule is that can't be a tendinopathy, but my likelihood is pretty high, almost certain, as Ebony would say. So although I'm not making a rule, I think my likelihood is going to be higher, but it is It's a good one. We just thought about any other tendon that we test, but then you think of like a flexor hallucis longus. Someone can do you can get them to plantar flex and bring down their big toe. They're like, yeah, it's soaring through here, and that's a slow movement, and that's obviously the flexor, but it's not a fast movement. Yeah.
So that's Steve just eating your words.
I'm just asking questions here, but I do find it.
Because the other thing that I was just thinking, in an athletic person, when you're doing like getting them to jump or hop, like it might be provoking their symptoms, but in those regions, it's sometimes a little bit difficult to differentiate if it's like a tendon or if it could be something bony or if it could be something else that might be around that area. Whereas in the Achilles, when you're getting someone to jump and hop, if it's provoking their symptoms, it's kind of obvious the Achilles.
Yeah. Yeah, I just think I'm extrapolating out for the Achilles because it's so easy to think of. But even for like an insertional tib post, I mean, it's still, if somebody jumps and lands, they're obviously going to be pronating, so they're going to get high compressive forces and high tensile forces, which is what you would get for the Achilles. So I just maybe need to be more aware of that next time to kind of rule in and rule out. But I think peritendon or fluid in the tarsal tunnel happens probably a little bit more than what I originally thought when I first graduated. I used to say, everything in the medial malleolar area was a tib post tendinopathy, and there's much more going on. I'm starting to see more, but I'm actually just starting to think of it more. Flexor hallucis longus as a common differential, because I used to think people just have discomfort as it wraps down under the arch down to the base of the big toe, but a lot of people can have it in and around, just underneath, kind of inferior medially under that malleolar. And it's funny because you get someone to push down on their big toe and like, yeah, I can feel the pain up under near the tarsal tunnel, which is such a weird thing because obviously you're not pushing anywhere around there. But yeah, it's interesting. All right, you're going to end it there, aren't you?
Yeah, that's the end of my week.
Finish it off. Beautiful. Enjoy this episode with Professor Ian Harris. What was your kind of origin story and backstory and where you come from and how you kind of ended up in this position? I guess all the research you've done and the topics you've looked at, somewhat controversial, but very, very interesting. And it's such an interesting topic to speak about in allied health and also in the orthopedic world. But how do you kind of get to that level? Because obviously starting at medicine, it's a pretty long journey to get to where you are now into this kind of niche topic. How did that all eventuate?
I started off following a pretty typical path, straight into surgery, from intern and resident days, and then trained as an orthopedic surgeon in Australia, and had a pretty general practice, but mainly focusing on trauma. And I would do lots of operations, and I was just probably doing all the operations that everyone else was doing. But I always wanted to be more of an academic and study these things a bit better. I didn't really understand how some people could interpret the literature really well, and I didn't have that skill of critical appraisal, and I didn't have the skills to do the research projects that I wanted to do. And so I started to learn that, and I realized that what I was really looking for was clinical epidemiology, which is really just the methods, the science behind or just the science, basically, learning about how to do science. And that opened my eyes. As soon as I started doing clinical epidemiology, I did a master's, I was kind of like, yeah, this is what everybody should know. It's not only what I need to know. I can't believe that we weren't taught all this stuff. And so that spun off. I really got into that. And then I did a PhD after that in epidemiology as well. And then started doing a lot of research, then took an academic position, and et cetera, et cetera. It sort of all sprang from there. But that was after I'd been an orthopedic surgeon in practice for several years.
Yeah, you mentioned, and you mentioned this in your book, which for everyone to go and read, the Surgery of the Ultimate Placebo. And I know you've got two books which we'll link below. But you mentioned in the book that previous mentors and through your surgical training, you were finding and noticing that the surgeries and kind of the treatments you were recommending and doing weren't really based in a lot of research. It was purely just based off, we'd done it for a really long period of time, and this is how we've always done it, and that's how we will always do it, which seems to be, especially in eye health and also in orthopedics. But how did you come to that realization? Was it something?
Well, studying for the exams, we had to get the right answer for every condition, and I was trying to look into it and say, well, why do we do this? What's the reason behind decompressing spinal cord injury? They go, oh, it's it's so it can recover. I'm like, but it doesn't recover. Like the damage has been done. So I don't understand what this is just what we do. And okay, well, there must be some evidence for it. There's nothing there. I started to realize that a lot of stuff we did, there just wasn't evidence for it. And in your orthopedic training, you rotate every 6 months. So I was going to a different hospital every 6 months. And I found that, the way we managed this condition depended on where you were. So as soon as you went to a different hospital, it's like, oh, no, we don't do that. We do this. And I'm like, well, you can't both be right. Like, how come they operated on it at this hospital, but they don't operate on it at that hospital? That doesn't make any sense at all. So clearly there must be a correct answer here, but there really wasn't. There's just opinions. And that's why some of the early research I did was looking into what is the evidence base for what we do as orthopedic surgeons, and found that there's, not a lot of evidence for what we do, although that's changing over time, but it's still not what people think it is.
I feel as being a physiotherapist, the main sort of surgeries that come to mind when you talk about that would be decompression surgery of the spine, as you mentioned, meniscectomies and shoulder arthroscopies. They're the obvious ones that I can think of. Would you agree with that? Is that what you have?
They're common. They're very common ones. So knee arthroscopy is one of the most common operations. Shoulder decompression is very common, but even rotator cuff repair. People think, well, the rotator cuff's torn, you got to repair it. Not a lot of good evidence that it actually helps, and we're doing a study now looking at that. And hopefully we'll be able to answer it. And spine surgery, particularly spine fusions, not a lot of good evidence to support them, and yet they're commonly done. And that's a big operation. It's a risky operation. It's a costly operation, and yet we don't have very good evidence for it.
So when it comes to kind of recommending, and this is in both worlds of orthopedics and allied health, I mean, if we're recommending a treatment, and the common saying of things it's a bit of a blend of art and a bit of a blend of science, how can we be I guess recommending these treatments if it's not really based on evidence, if the person that's going to be receiving those treatments potentially is assuming that, things of consent, medico-legal stuff, especially with surgery, where the consequences are quite high. I mean, what basket does that fall into, and what are your thoughts on that?
Well, we shouldn't be recommending it. I don't understand this art versus science thing. I don't know what the art is. I mean, there's to me, there's the only way of answering a question is in an unbiased, scientific way, and an operation either works or it doesn't, or it works in this person or it doesn't in that person. There's no art about that. But when it comes to, I'm not sure, I think you had a few questions there, but it's like, what should we be recommending these things, or why are we recommending these things?
Yeah.
Well, the reason why surgeons are recommending them is because they think they work, but surgeons don't realize that that's a biased interpretation. And the reason why surgeons think they work is because, for example, with knee arthroscopy for degenerative meniscal tears, they believe it works because the patients say they feel better afterwards. But that doesn't mean that they feel better because of the surgery. And I learned that before I started clinical epidemiology, because I used to do a lot of knee arthroscopies, and I did so many of them that I got a waiting list, and then I would see the patients in the anaesthetic bay before operating on them after having not seen them for 6 months. And I'd say, how's your knee going? And they'd say, it's fine, no problems at all. And after doing nothing to them. And that's because that was the natural history of a condition. You see somebody when their knee is particularly bad, you do anything to them, it's not going to be particularly bad all the time or unusually bad all the time. It's going to go back to what it was. It's either going to get better or it's going to go back to its usual kind of grumbly pain. But studies now, many studies have shown very clearly that their probability of getting better is not changed whether you operate on them or not. Now, the important thing is when you look at those studies and they compare, say, arthroscopic meniscectomy to exercise or arthroscopic meniscectomy to placebo surgery, it doesn't matter what they compare it to, patients get better. So a lot of the patients get better in both groups. And if you're only looking at the group that you operate on, you're going to say, well, a lot of my patients get better. And therefore they're getting better because of what I did. But they're not. They would have gotten better regardless of what you did to them. They're not looking at what we call the counterfactual. What would have happened had you not done that? And then you compare the factual to the counterfactual, and that's how you find out whether things work or not by simply observing. You find out if things work by experimenting and comparing. You don't find out if things work just by looking at it. Otherwise, if you just relied on observational evidence, then everybody would have a cure for the common cold and they would all be 100% effective. But none of them are, because people get better anyway.
The COVID pandemic would have been an interesting time to observe this, I suppose, when elective surgeries were paused over that period. Did you clinically notice a difference over that time where people were just having to wait out these painful knees or shoulders and actually getting better? Or what did you find then?
Well, I personally didn't notice a difference because I don't normally recommend surgery for them anyway. So I didn't really see a difference. I haven't seen a huge bounce back, but I don't know what the numbers are. But I do wonder. I mean, that could probably be looked at by looking at the number of operations that were not done during that time to see whether there has been an equal increase in the numbers since then. I would think probably not, because a lot of those people just didn't bother getting the surgery because they were doing okay anyway.
Yeah. And I guess that ties into like the bias of it as well, in terms of potentially patients presenting with a painful knee and then maybe getting put onto a wait list or having a surgery scheduled in at some point later down the track. But if they do follow that natural history where things start to feel better, or perhaps they start to get involved in some sort of exercise intervention, they probably like deselect anyways. So they're not necessarily followed up to see that natural history has been effective in like anecdotally, I suppose.
Yeah, but even if they were surgeons, well, clinicians, I'm blaming surgeons because that's what we're talking about, but clinicians are biased. It's been shown in many studies that clinicians overestimate the benefit of what they do and underestimate the harms. And it's fairly obvious to me. I guess it's not obvious to everyone, but it's clearly been shown. The problem with that, you may think, well, that's fine. I mean, everybody kind of overestimates what they do. They all think that they're a little bit better than average. But the problem is when it comes to making a decision as to whether or not to have surgery, that decision is largely dictated by the surgeon. The surgeon's going to say, well, yeah, I think you're a good candidate and you're going to do fine. That decision is based on the surgeon's perception of the probability of benefit and the probability of harm. That perception is not true. That perception does not reflect the reality of the probability of getting better or the probability of harm. They're overestimating the probability of getting better and underestimating the harm that may occur. And that's the problem. If the decision for surgery was being made on objective criteria, I wouldn't have such a problem, but it's not. It's being based on biased criteria.
I have an example sort of tied into that of a patient who was through DVA, and they were booked in to have a shoulder decompression surgery, and they hadn't tried any non-operative management. I got the impression that that surgery was encouraged because they were being discharged from the defense and moving to DVA was the scenario, and it's almost like this pressure to intervene in some ways. And it was quite difficult being in this position where a surgeon had recommended that that's what this person needed and it needed to happen within 2 weeks. My understanding was that there was other options that could be tried first, and I don't feel as though I'm in a position where I could, I guess, debate that and have a positive effect almost from it. What would your recommendation in a scenario like that be?
Yeah, so that's true, and that's a problem in that unfortunately, when I say this as a surgeon, surgeons hold a position in society where their judgment is highly valued. And when a surgeon says, "I think you need surgery," then then the patient, it's difficult to say you don't. And so that's just a reality of the society that we live in. I don't think it's healthy, but that anybody should not be able to be challenged or, open to scrutiny. But unfortunately, that's the way we are. So the way to approach that problem is to educate patients better in taking more responsibility for what happens to them, because unfortunately they divulge that responsibility to the surgeon, and they just say, "Well, you tell me what do you think? What would you do? I don't know. If you think I need the surgery, that's fine." Instead of asking questions and some simple questions like, "What is the probability of me improving with surgery compared to if I do not have surgery?" Just getting back to what I was saying before. And even a simple question like that can throw surgeons a little bit. And asking for the evidence. What is the evidence that this is better for me than not doing it? And it might provoke quite interesting responses. The other thing you can do is get a second opinion. If the patient isn't sure, they can get a second opinion, because second opinions vary widely. There's been studies looking at spine surgery, for example, where simply getting a second opinion dramatically decreases the probability of getting surgery. And that a lot of people who get a second opinion surgery, about half the people who get a second opinion find out that the second opinion differs from the first opinion. Either they think they need a different operation or they need no operation. It's all over the place. So a second opinion is certainly a possibility.
And you mentioned this in your book, how we might look at what is a successful outcome, whether it be if you take an X-ray and the bone's united, or if someone can get back to running but they still have discomfort. That there's lots of different ways that people measure success. When we look to the research, what is the kind of standard definition of what is a successful surgery?
It depends what the surgery is trying to achieve. So if I'm doing surgery to get an ununited fracture to heal, then the definition of success is the united fracture. If I'm trying to correct a deformity and restore somebody's gait by restoring a limb length discrepancy, then the outcome would be their gait, but it would also be my ability to achieve the equalization of their limb lengths. But for a lot of what we do in musculoskeletal surgery, though, it's treating pain. Pain and the associated functional limitation from pain. So it's pain and function. So success for surgery is usually measured in scores that measure pain and function.
Yeah. And do you think that's a good way to do it?
As long as it's done in a way that compares it to not doing surgery. Because if you simply measure pain and function after doing surgery, you have no way of telling whether that change in pain and function is due to the surgery or not. This is the problem with registries. I've been involved in several registries over many years, and there's a current call for a registry to solve the problem of spinal cord stimulators, because there's been a lot of debate about the effectiveness of spinal cord stimulators for chronic pain. And I, for one, have been fairly vocal in saying that the evidence is that they're probably not effective. Yet they're commonly done, and they're very expensive, and they have high revision rates, etc. And so the answer for a lot of people is, we need a registry. Once we get a registry, then we'll know exactly how effective they are. And my response to that is that if you form a registry where you followed up every single patient in Australia that had a spinal cord stimulator and you measured their level of back pain afterwards, you would have no information whatsoever on how effective spinal cord stimulators are. it would tell you nothing about the effectiveness.
Mm.
And for example, the Australian Joint Replacement Registry doesn't tell you how effective knee replacements are compared to not doing a knee replacement, because it only measures knee replacements. It's only measuring one side of the story. Now, it can tell you if there's a difference between a certain type of knee replacement and another type of knee replacement. It can tell you whether there's a difference between the anterior approach for the hip and the posterior approach for the hip. It can tell you whether there's differences in using a large head hip than a small head hip. It's great for all of that, but it tells you zero about whether a hip replacement is an effective operation for arthritis. It just doesn't tell you that. It's not built to tell you that. It's not designed to tell you that. So, sorry, I kind of sidetracked from your original question, but
that's good.
I think I'm getting a point across.
So the idea of having, studies where you have a control, and that's, one of the main points, you have to have that to compare if we don't do the intervention. How does that work in surgery? Like we were saying off air, we have lots of messages come through on the social media around, something like sham surgery is unethical. But of course, people are informing for consent. They understand they might be one of two groups. But how does that typically work in a research point of view and the ethics around it, and what typically happens at the end? Because as you've said, we've mentioned, a lot of studies are showing there's not that much of a difference, if any, between not doing it and having surgery.
Yeah, well, there's no issue with the ethics for research. There's an issue with the ethics of using placebos in clinical practice because they're not effective. And in clinical practice, we shouldn't be exposing people to harm without a benefit. So in clinical practice, we shouldn't use it. But in research, it's very common. I mean, the placebo drug research is being done all the time, and these are harmful drugs. People are getting randomized trials of highly dangerous drugs. So it's not unusual for people to be exposed to risk in experimental trials, but that's why we have consent forms and explanations, and people realize they're volunteering. But if they're volunteering for a placebo surgery study, their risk from being on the placebo group is lower than their risk on being in the active group, because the risks involved in placebo surgery are less than the risks involved in the real surgery, because it's less of an operation, less invasive. So ethically, it's not an issue. I mean, I've been involved in several placebo studies, and they've gone through ethics first pass, normally with congratulations, because this is a very good scientific way of assessing effectiveness. There's no argument from the ethics committee on the research side of using placebos. That's not an issue. People understand that they will be blinded and they will not know whether they have the active intervention or not.
And how do you explain placebo? And in your book, you talk about it as, there's many a definition, but how do you typically see it reported? Because most people say it's a nothing option, that it's nothing, but it's a lot more than that. There's contextual things.
It's very confusing. It depends on you. Sorry?
I'm not just laughing because it is confusing when I was trying to look up definitions. I'm interested to hear your opinion, because there's lots of different ways to report it.
Yes. So it does depend on your definition. As long as you define it up front, then that's fine. And I think in the book, I define it as anything that's not the specific effect of surgery. So in other words, non-specific effects. But those non-specific effects are made up of things like natural history, which we've talked about before. So if you want to call that part of the placebo response, then that's fine. But I think it's a bit confusing to do that, actually. And these days, I try not to use the word placebo because it's not very helpful. So I'll talk about blinded studies, and because really it's just a technique of blinding in research. And there is no effect from the placebo. There cannot be, otherwise it wouldn't be a placebo. The placebos have no effect. That's very clear. And a lot of this stuff, particularly recently, about these open label placebo studies and how effective they are, they're not effective. It's the thing that is delivered in one group that differs from the other group that makes it effective. So when you have an open label placebo study, what they do is they say to people, they'll give them an educational video, they'll tell them how effective this is going to be, how this has been shown in studies to be effective. We expect a good response. And in the other group, they don't tell them that. So it's the difference in what they tell them that causes the effect, not the placebo pill they give them. So again, there's confusion. So they're calling that a placebo effect. It's not a placebo effect. It's the effect of educating people and raising their expectations. So placebos have no effect. Even in studies that purport to show a placebo effect, they're testing something else. They're testing the context in which the intervention is given. But we've looked at placebo effect in surgery, and there is no placebo effect in surgery. It's studies that have used placebo groups and studies that have used no treatment groups, like not a placebo, just nothing, show no difference. There's very little difference between having a placebo operation and having nothing. So there is no, surgical placebo effect in surgery. What you're looking at, what our studies have shown, is that roughly 2/3 of the improvement you see after surgery from pooling all of these studies, placebo studies, is the natural history. It's what would have happened to them anyway.
Which is unreal to think about. Like, that's a lot of people and just a lot of time and energy and money and just, potential risk and things to go into that for that to be a conclusion. Like the contextual cues, I feel like in the last couple of years, it's in our space definitely talking about the context of back pain and heel pain and the environment that people are in. And there's so many things that can play into, someone's hypersensitivity or their function. But this idea of which you speak about in the book as well, the perceived and true effectiveness of surgical interventions, which obviously plays into allied health. But can you just define those again? I know you said them before, but the true and perceived effectiveness.
Yeah. So after you treat people, you will see an improvement. So that's the overall effectiveness, or the perceived effectiveness. That's going to be made up to some degree, somewhere between 0 and 100%, of the specific treatment effect of the intervention you give. And it's also going to be made up of non-specific effects. And those non-specific effects can be natural history. And as I said, that's probably 2/3 of the whole thing. But it can also be contextual things. So their confidence in the person delivering it, the interaction between the therapist and the patient, their expectations of improvement, and a concomitant treatment. So other things that they might be receiving as well, the anti-inflammatory pills they take or something like that, which can also contribute to the overall perceived effect that we see. And the trouble is that practitioners tend to see the overall perceived effect and attribute 100% of that to the treatment they just did or gave earlier or whatever.
I want to ask you a question specifically to like meniscectomies, because that's probably a surgery that I would most commonly see out of any of the ones that we've spoken about so far. And I wonder if, I'm interested to get your thoughts around, is there a time and a place that there is benefit to have a meniscectomy? So for example, when there is an associated ACL rupture, or if for some reason it's not a repairable meniscus tear that has mechanical symptoms, or for example, I was just chatting with one of my colleagues doing a mentoring session, and we were talking about, say, like in a paid sport, when there's that pressure to return to sport, and a meniscus repair does have that sort of lengthy time period for recovery, opposed to something like a meniscectomy where they seem to be back playing sport reasonably quickly. Is there any scenario that you can see where there's utility in a meniscectomy, or would your advice be to stay away from them completely?
Well, most of the patients that have been included in the research are patients that do not have a locked knee from a bucket handle tear, for example. Yeah. And so they're normally excluded from those studies. And you can make an argument that if somebody's got a locked knee, that by removing the meniscus, you can free up their movement quicker. So that's one sort of big exception. And I tend not to do it for anything else, really. And I don't think that it gets people back to sport any faster. And one of the things you're going to say, I picked up on, but I can't remember now. But mechanical symptoms. Yeah, mechanical symptoms are rubbish. People don't know what that means. They've tried to define it, and they've even looked at reanalyzed placebo studies where they've only looked at people with mechanical symptoms. And interestingly, when they did that analysis, they found that there was a bigger difference between groups, in that those who had surgery did worse if they had so-called mechanical symptoms. So it's just rubbish. It's just something that sounds good. You've got to be careful with surgery and practitioners in general, that people often say things that sound good. They sound really good, but they're rubbish when you think about it. And one of those is, oh, you've got mechanical symptoms, so we need to do something mechanical to you to correct that mechanical problem that you have. But the whole concept of mechanical symptoms is dodgy. The other thing that surgeons say is, well, you failed non-operative treatment, therefore you need operative treatment. And again, that kind of sounds good. Yeah, well, somebody's failed non-operative treatment, so they need an operation. That's not true unless the operation you're offering is effective. If you're offering an operation that isn't effective, then the failure of non-operative treatment doesn't make it effective. It still doesn't work. So you have to think through these things a little bit. It's just so easy. It's so easy to sell surgery. I see patients with a acute clavicle fracture. Now, I can say to them one of two things, and probably they will mean the same thing to me, but they'll mean something very different to the patient. So I can explain to them the evidence about a non-operative versus operative treatment, and the risk of non-union, the risk of maybe needing further surgery or having the plates removed afterwards, and we can go into the sort of balance of it and have a long discussion. Or I can say to the patient, well, that's the evidence. What do you want us to do? We can either leave it alone or we can fix it. And what's the patient going to say to that? Now, I'm using the word fix, meaning to fasten, to internally fix. So we can either internally fix it or plate your fracture, or we can leave it. And by leave it, I mean treat you non-operatively and wait for it to heal by itself, which it will probably do. But when somebody hears those words, we can either leave it or fix it. That sounds to them like, well, we can either ignore you and just forget about your problem and not even offer you any treatment, or we can fix your problem. So if I say I can leave it or fix it, then patients will say, well, I want you to fix it every time. So wording is very important in influencing patients' decisions.
Yeah, I find that very much with the term stability. It can mean 100 different things, and it's very.
A lot of it is rubbish. I'm going to blame the physios for a lot of that too. But you see it in spine surgery. It's spine surgery. It's like that as well. Oh, your spine's unstable. Is it? Is it really? What does that mean?
Yeah.
Oh, it moves more than 2 millimeters. So what? Is there any evidence that that's correlated with pain? Or is there any evidence that if you operate on that particular problem, that they will get better? No, none. And yet it just sounds good. It's unstable, so we're going to stabilize it. Hard to argue with that kind of use of words, even though there's no evidence behind it. But everybody these days talks about sacroiliac instability and this instability and that instability. And it's all pretty dodgy to me, but I'm an old cantankerous skeptic. So my radar's up for anything like that. As soon as somebody comes up with something like that, I'm like, it's probably going to end up being rubbish, because I've been saying that for a long time and I'm proved right nearly every time.
Do you often, I know you've referenced leaving it and waiting for it to heal. Do you truly mean that that certain areas will heal, or do you mean they'll just become non-symptomatic over time?
It depends what it is. Yeah. So some things heal, like fractures heal.
Yeah.
And we've learned recently that some ACLs heal.
Yeah.
And my teaching was that an ACL tear will never heal. They will not heal. And now we're seeing all these examples of healed ACLs treated without surgery. All of a sudden, like that wasn't happening before. We just didn't want to believe it. I don't know.
Yeah. Are you recommending patients to go and see a physio or exercise physiologist during that time period, or like after you're recommending to them that a surgery might not be useful?
Depends on the condition. For ACLs, I do. Yeah, but for a lot of things, I don't. Degenerative meniscal tears, these are people who basically have osteoarthritis. I just get them to lose weight, remain active. I don't send them to a physio, but I'll send an acute ACL to a physio, and some fracture, because I treat mainly fractures. So depending on what the fracture is, shoulders, for example, that's a famous one where they do get a lot of stiffness. So nearly all of them I'll send to a physio, because they need somebody to monitor them and to push them a little bit and to get that range and strength back. But for a lot of other fractures, it's not necessary. Patients will do fine.
I wanted to ask Ian, you mentioned before around kind of non-operative and operative treatment, and if someone's failed non-operative, the next logical step is always you go on and have an operation. And I guess in the allied health world, we can sometimes get caught where we implement something, we see the effectiveness, and if that doesn't work or work to as much as what the person wants, we just go to the next thing and the next thing, and if that doesn't work, we just keep going until we find something. Do you think that a lot of that problem stems from perhaps people not being able to have the conversation of, we've done all these great things, potentially it's going to be a case of we just need to manage your osteoarthritic knee, your ankle, or your plantar heel pain, and let natural history take its course and focus on other things? Do you think that's one of the reasons why it happens, and we say, no, let's just try this and keep going and going and going until we end up, probably further away from the evidence?
Until you end up with them getting better anyway, and then you attribute their improvement to the last treatment that you tried. Tennis elbow, all these sorts of conditions that are, well known to be self-limiting and will improve over time. There is a case to educate the patient, just say, look, it's not terrible what you got. We know that it's going to likely to improve over time. De-escalate it, reassure them, and that can be all the treatment that some people require. But unfortunately, we see not intervening as a failure to care.
Yes.
And you have to educate people about that. And that's one of the reasons why we do intervene so much, is because, well, at least we're doing something. That's not necessary all the time for us to do that.
We have a great quote that says, through my studies, I came to realize that more medicine wasn't necessarily better, and in many cases it was bad, which ties into that quite well, and I definitely agree. I mean, in my world of podiatry and below the ankle, I was someone that really thought that the shockwave was quite effective, but some of the studies comparing that to sham and comparing it to no, it doesn't seem to be, to people that don't get it, doesn't seem to be that much more effective, or if anything, it seems to be much the same as not doing it. So we do need to look to the evidence quite a lot and not always assume that more is better.
I think my example that I would see a lot in the physio space would be in chronic low back pain, where I think, my goodness, like this person who's had this like back pain for 10 years and seen so many different healthcare professionals over that time. I wonder if they just never saw anyone from the very beginning, if they would still be in the situation that they're in right now. But I feel like that quote really resonated with me as well.
Yeah, that's right, because it reinforces that the more people they see, the more investigations they get, the more different diagnoses they get, because every different specialist will give a different diagnosis. And the more it reinforces to them that there's something wrong with them, and reinforces the sick role, and it's not necessarily helpful. And a good education session and some reassurance from the start, and these sort of pain education courses that educate the patient about self-reliance and coping mechanisms, and think would have been better from day one rather than being shuffled around looking for, what I sometimes call the black spot, looking for the one test that will show a black spot that will diagnose their pain. And as soon as we remove that black spot, all their pain will go away. That's the way people think about pain, but clearly it's not like that in real life.
I feel like something else that is often sort of seen in the general population as well is they have more tests, and the more tests or investigations they have, the worse that they think the problem is. Whereas what maybe would be a better message is that the more tests that you have done, the more likely it is that there's nothing sinister or nasty. So that almost needs to be reframed in some ways as well.
Yeah, it doesn't. One of the problems there is that every test they do is going to show many things.
Yeah.
I've never seen a normal MRI scan, ever. I've been in practice for 40 years. I've only seen MRIs for maybe 30 years, but you just don't see normal MRIs. There's a page or two of things wrong with it, but it would be better just to say there are no changes beyond what we would expect for your age. A one-line report would be a lot more reassuring for the patient than what we get with our current MRI reports. You should only investigate people if it's going to change your management. And a lot of the time it's not going to change your management, and it just adds worry and reinforces to the patient that they've got something wrong with them that needs to be corrected. Either through physio, surgery, injections, spinal cord stimulators. There has to be a cure for the thing in my back that is causing the pain. And by the time they've had back pain for that long, it's not the thing in their back that's causing it. It's more likely to be a complex pain phenomenon.
And have you found, people coming to see you, and your recommendation of surgery, for most of these conditions is going to obviously be lower. How are you finding people's initial reaction to that? Can I think of someone who has had back pain, heel pain, ankle pain. It's painful. They're worried. They're scared. It's been going on for a while. Lots of contextual things affecting their quality of life and their psychological status. It's almost like an extended sympathy of them just wanting to go out and find someone who's going to have the answer. Have you found for yourself a lot of the time people just say, yeah, whatever, and just go somewhere else, and they look for something else until they find that person?
Not often. Sometimes patients vary a lot, as you'd expect. But and I often go in thinking, oh, gee, I'm really going to have to spend a lot of time explaining to this person why I'm recommending against surgery, because they've been referred to me for a second opinion and someone else has recommended that they have a spine fusion or something. And it doesn't take long sometimes when patients go, no, that's fine. That's all I wanted to know. I just wanted to know that you think it's okay not to operate, because I didn't want to have surgery. And I'm happy just to put up with it. I'm actually doing fine. I just wanted to avoid surgery. And I'm kind of, okay, well, fine, there you go. But some of them you do need to, have a lot longer explanation.
I guess it's just raising doubt in some ways. If you can create any form of doubt in that person's mind, then they immediately start to think of other likely alternatives.
Yeah, and I can honestly say to a lot of my patients, again, depending on the condition, I can say to them, look, you've got a condition. If you saw 10 orthopedic surgeons about this specific condition, you might find that, whatever the condition is, 5 of them would operate, 5 of them wouldn't. It's just not that clear that you have to have surgery. A lot of people think that as soon as surgery has been suggested or recommended, that they have to have it. I don't think anybody has to have elective surgery. It's a decision they have to make. And I was surprised when you brought up the example of your patient earlier with the shoulder decompression that had to be done within 2 weeks. I mean, that's not an urgent condition. That doesn't have to be done within 2 weeks. And so clearly there's something wrong there for the surgeon to say that. And the surgeon wants to get it in before the coverage lapses or something like that.
Yeah.
But you said it's very hard to have that competing conversation at times. Now,
it is.
Talking about other treatments that may not be as effective as one thought, the lovely PRP injection, which is something that people talk about quite a lot in allied health, and there's been some maybe competing studies. I remember when I graduated seeing a study that people were saying like this is going to be the best thing for plantar heel pain. Then it was for tennis elbow, and then everyone's doing it, and then not that many people doing it, and then there's been banned in certain countries that certain practitioners aren't allowed to use it, and it kind of just goes on forth. I wanted to ask two questions here. One is, what are your, I guess, general thoughts on PRP? Why do people think it's good? What does the research say? And then secondly, from a practitioner point of view, how much research and evidence do we need until it becomes like malpractice to be doing this? Like if we have clear studies that show that it's not effective, how far does that need to go before someone can actually get in trouble for recommending it, even if people are saying that they want it?
Unfortunately, that will probably never happen as long as people are doing it, because the benchmark is, are people doing this? And if the answer is yes, then this is a reasonable intervention. The benchmark should be, does this work? Is the evidence that this is going to be a net benefit or a net harm for the patient? That should be the benchmark. And if it's going to be a net harm, then we shouldn't be doing it. It should be negligent to do it. But the net harm is that, well, this is what other people are doing, so it's okay. And that's what enables us to get away with a lot of what we do, because, well, this is common practice. So unfortunately, that almost never occurs. But it should be, and particularly for PRP. I mean, I'm not all over the evidence for PRP. I've stopped looking at it years ago, but because everything I saw showed that it wasn't effective, and even when it wasn't effective, people were interpreting studies to say that it was, and then they say, oh well, no, it's just we do it differently because there's a million different ways you can prepare it and inject it, and so people cling on to things, but the evidence for PRP is woeful. It really is, and I think it's a complete waste of time. I don't know of any strong evidence that, from a properly blinded and methodologically rigorous controlled trial, that it's helpful.
And I mean, as you said, I think it's worth speaking to just the idea of doing something and seeing an effect. And you talk about this at the very start of your book, where there's things like regression to the mean and natural history. Are there other factors at play that we might not be aware of? And I think like social media is the big one, where someone does something and they're like, yeah, I did this to this person and they improved, and people are like, oh, okay, that obviously must work. So there's three that you mentioned. One is regression to the mean, natural history, and I think there's another one,
concomitant treatment.
Yeah, can you explain that one? Because that's a great phenomenon.
Concomitant treatment. It's just that it's the other treatment they're getting anyway. So, for example, we're doing a study at the moment where we're comparing, and this is a good example of the use of the word placebo. The original title of the study was a placebo trial of the effectiveness of rotator cuff repair for degenerative tears. We changed the title to a randomized controlled trial comparing arthroscopic surgery with rotator cuff repair to arthroscopic surgery without rotator cuff repair. And that to me is a much clearer description of what we're doing, rather than saying it's a placebo study. But patients in both groups will get put in a sling afterwards, as if they had a rotator cuff repair. So their shoulder will be rested for a long time, and then they're going to have a very prolonged course of a graduated, which is just the typical post-cuff tear, graduated phased physiotherapy program where they gradually increase their resistance and their range, etc. So it's, I have no doubt that patients in both groups on average will improve. I don't know whether they will improve more with the rotator cuff repair or not. That's why I'm doing the study. But I won't be able to tell how much of the improvement is due to the physio they're getting as well, or resting it for a while and then putting themselves through a graduated program. The only thing I'll be able to conclude is whether repairing the rotator cuff adds anything. So you've got to look out for what other treatment people are getting at the same time. I give a few better examples, but they're surgical examples in the book of where people have compared two treatments and thought them to be effective, but it was just the fact that they were getting this other third treatment in both groups that actually made them better.
It's like the A plus A compared to A plus B, or this group getting different things. It's so hard to nail it down to this one little difference where there's other things happening. Like from a research point of view, how does it tend to happen? I mean, there's clear biases and problems with some of these studies. How are you thinking that they get through and approved, and these things aren't thought of, or they are thought of and people just don't care? What do you think?
Well, the study that I referred to is a good one because both patients will be treated exactly the same in every way. Preoperatively, they'll be the same. They'll be randomized so that their baseline characteristics will be the same. They'll have the same other surgical procedures done on their shoulder before they get randomized, and they won't actually be randomized until they're in the operating room. And then after they've had the other procedures done and their eligibility has been confirmed, they'll be randomized to having the cuff repaired or not. That will be the difference between the two groups. Afterwards, they'll be treated exactly the same. Their knowledge will be exactly the same because they won't know what group they're in. So we'll have a situation where a patient's gone through a whole course of treatments, of time, of natural history, of having physio, of all of these other things done to them. But both groups will be exactly the same except for one thing only, whether or not they had their cuff repaired. So any difference that I see between those two groups must be due to the cuff repair. So scientifically, that's how you do a good study.
Are you so for this study, for example, if it does come out where there are some patients who have a really positive effect and then some patients who have no effect at all, and the average of that kind of washes out to be somewhere in the middle, does that mean that that's not been an effective intervention? And same thing with like previous like meniscectomies.
Yes, it does. Yeah, it means that it's not been effective because it means the probability of improvement, however you measure that, is the same. So both groups, not every patient in every group is going to improve by 33% or whatever it is that the improvement is. That's going to be the average improvement. Some people would have got worse. Some people would have improved 100% in both groups. The only thing we can say is that the probability of you improving is the same whether you have the treatment or not. And you can define improvement different ways if you like, and you can even use a threshold, and you can say, well, we don't think a patient has had a successful outcome until their score has reached a certain level, or until they have less than 3 out of 10 pain, or whatever the threshold is that you're trying to achieve with the operation. But as long as the proportion of people who achieve that is the same in both groups, then the treatment is not effective. It doesn't matter, what the variation is. You've shown that the probability of improvement is the same. And that probability of improvement doesn't say whether you may improve 100%. You may get worse with the operation. But we don't know that until we do the operation. All we know is that the probability of them getting that is the same as if they don't have the operation in such a study, if it shows no difference. But if the study shows that those having the rotator cuff repair are twice as likely to reach this threshold of improvement, then that still doesn't guarantee that a patient that I'm about to operate on will achieve that improvement. It only tells me that the probability of them achieving it is greater if they have the surgery. We only deal with probabilities. We don't deal with facts because we don't know the facts before they occur.
Do you see a place for the future in an example like this where maybe researchers could look into that a step further and try to decipher between which patients might be one to experience a positive outcome versus those who wouldn't, and then those people could potentially go on to some kind of intervention?
What you're getting at is what a lot of people say when they see studies and they go, okay, what is it about the some of those patients that made them improve. So can we predict the responders? Sometimes you can, but your ability to predict the responders, so you say, well, let's look at, for example, in the knee arthroscopy study, people said, let's look at those in your study that had mechanical symptoms, because we think they're the ones that are going to respond better. And by having those without mechanical symptoms, it's all washed out. You just need to look at those. And they did that, but they still found no difference. So, and a lot of the time, the reason why people got better is because of natural history. It's not because they had some unusual condition that responded to the treatment. That's actually the way it works. And I've just seen this so many times where we think that, oh, there's a responder. There's a famous study I presented. I didn't do the study, but it was a great study because it looked at a particular intervention for back pain. And it was, the name of it now, but it's where they IDET, intradiscal electrothermal therapy. So you put a probe into the disc, the degenerative disc, and heat it up, and it's supposed to shrink the disc and help their back pain. And it's $1 million industry, and people get this treatment all the time. It was very popular at one stage, and it was thought to be effective because so many people got better afterwards. And it wasn't until a group in Adelaide did a study where they put this probe into everybody's spine who was in the study, and only half of them were turned on and half of them weren't. So it was a placebo study. And they found no difference. They found a 25% improvement in the active group and a 25% improvement in the non-active group.
Wow.
When I presented that at a meeting, one of the spine surgeons said, this is fascinating. We need to find out who those 25% are, because they're the ones we should be doing the procedure on. And I said, no, you don't understand, because those 25% also got better when they didn't have the procedure.
Yeah.
So it just sounds good to say, oh, 25% of them improved. What is it about those people made them improved? I'll tell you what it is about those people. Those people would have gotten better anyway. That's what it is about them. So it's not that we should be targeting those people and operating on them. That's not what the study tells us. The study tells us that the probability of them getting better is no different than if they don't have the treatment.
I like these terms in your book that I hadn't actually ever heard before, and I think I'm going to bugger them up, but like pea squashing, or people that go out and looking for
Pea
something.
hacking.
Pea hacking, that's it, pea hacking. And I was like, it's sad to know that that's the case, but I was like, it makes sense. People can go out and do it, and use a couple of examples where, if you just don't report all of the data, you can kind of always sculpt it to make it look how you want.
You could still report all the data and make it look like it's significant. It's very easy to do. I study statistics and I do a lot of my own statistics. It's very easy to do. And this is why you always see p-values of 0.049. And you never see a p-value of 0.051.
Yeah. Now, thank you, mate, so much for coming on. We'll have all our links below and links to your books as well. But we always ask our guests this one question, and we purposely don't send it through prior. So 2 questions. Number 1, if you could interview anybody, just sit down with them one-on-one, who would it be? And then secondly, and this is going to be a good question for you because I'm sure you've thought about this, if you could do any form of research, recruitment is not going to be an issue, ethics won't be an issue, you can do anything that you like, what would you do and what would you look at?
Interview someone to, I don't know, I've spoken to all the people I want to speak to. So, I don't know. But
Maybe speak to them again.
Yeah, there's a lot of very famous thinking people, scientists in the world who have been, phenomenally influential in our use of science over non-scientific things. And people that have, promoted it in time, like, I'm getting mental blanks here, but, the physicist Richard Feynman, he did some fantastic speeches, and people should look up his, I think it was a Caltech, they have these graduation speeches or commencement speeches or whatever in America. They get famous people to do them. He did a fantastic one on that. And, complete mental blank. The guy, Carl Sagan. the guy who wrote Cosmos, a great science promoter, dead now, but would have been fantastic to talk to or listen to. And what was the last question? Oh, what study would I do?
Anything at all, any study, no ethics problems. You've got billions of dollars. Any issue is solved.
Yeah, well, it would have to be, spine fusion versus pretend spine fusion, or spine fusion versus no spine fusion. We're doing a study on spine fusion versus no spine fusion at the moment, but we haven't started.
You're already doing it. You're already living your dream.
Yeah, we're living the dream. I think that'll be a good one, but it's not a placebo study.
Yeah. No, very good. All right, thank you so much for coming on. We really appreciate it. It's a great chat.
My pleasure. Thanks very much for having me.